will start with the osteoarthritis, the newer advancement in osteoarthritis treatment. Primarily, we'll start with. Can you see the screen now?
Yes, we can. We can see this.
Okay. So we'll start. Yeah. So, what is osteoarthritis? It's also known as the wear and tear arthritis. The cartilage, the lining of the joint, the smooth lining of the joint is worn off because of some degenerative process, or sometimes it's because of arthritis. And secondary to arthritis, secondary to trauma, so it is a destruction of the cartilage, the smooth surface, so the bones rub against each other, causing deformity, causing osteophyte formation, causing pain because of multiple reasons like increase in the joint fluid, swelling, like capsule stretching by the osteophytes causing pain, and by mechanical irregularities between the two surfaces that are rubbing each against each other, causing pain, the cyst formation. And it is most commonly seen in female gender after 50 years, and it is a huge burden in our society. More than 65% of the population above 60 suffers from osteoarthritis. Mostly in India, we see knee osteoarthritis. And in knee, the common deformity we generally had is, I think my slides are not working properly.
I have made you the host of the meeting. So
Okay.
I think it might be better now.
Yeah. So it is commonest cause of long-term disability in older population, and it's not like inevitable part of aging. Some patients suffer from osteoarthritis earlier than the age. I am replacing knee joints at the age of 50 years also, sometimes at the 45 years. So there are multiple combination of different factors that are involved. Both mechanical, biological, destructive processes play a role in the osteoarthritis process. So, what are the risk factors in osteoarthritis? There's the first, the age, because it's a degenerative process. Female gender, because of the postmenopausal osteoporosis, because cartilage is just like a tile over a wall. If wall is supporting wall is just like a bone, bone above the bone is a cartilage, and it is half of the cartilage takes the nutrition from the towards the side of bone, takes the nutrition from the bone, and half of the cartilage takes nutrition from the joint fluid. So the nutrition of cartilage, when it becomes less, it increases the chance of wear and tear. So female with osteoporosis, weak bones, the bones are not supporting the cartilage properly, so they had a tendency to suffer more from osteoarthritis. Likewise, obesity, as much as high weight, increased weight is borne by the knee. So knee are more tend to degenerate earlier. Any previous knee injury, any fractures around the knee, any ligament injuries, any old malalignment like a varus knee. Sometimes patients from the childhood had a varus or a valgus knee. So they had a mechanical malalignment, so increases stress around the knee joint. And high impact activities, sometimes high impact activities like running and jumping on hard surface for long can cause osteoarthritis, and muscle weakness are the some of the factors. So we classify osteoarthritis in two groups, like primary and a secondary osteoarthritis. Primary is idiopathic, localized, maybe generalized, primarily involving knee, hip, spine, and hands. And secondary is mostly because of post-traumatic, maybe inflammatory, post-arthritic like rheumatoid arthritis or any other arthritis causing joint damage, or avascular necrosis generally happens in hip joint. So there are a few cases where we see hip osteoarthritis post-avascular necrosis. So it is a look inside the joint. It is a pristine look. You can see arthroscopic view on the left side. You can see the shining white cartilage, and on the right side you can see the cartilage is worn off. It has been coming out of bone. It is irregular. Somewhere it is there, somewhere the bare bone pinkish in nature you can see in the arthroscopic view. So the x-ray looks like, you can see a left side is a normal x-ray of a knee joint with a pristine joint line, equal joint line. The right side you can see the joint line is gone, the bone is rubbing against each other. So cartilage which is protecting the rubbing is worn off, so they produces symptoms because of the rubbing of the bones, bare bones against each other. So in history tests, you should rule out inflammatory arthritis like ESR, CRP, rheumatoid factor, all the arthritis profile you should have for all the patients of osteoarthritis, because sometimes they might had a inflammatory arthritis, not only the degenerative part. X-ray, what I feel is the weight bearing anteroposterior X-ray is the most prominent. We can see the varus or a valgus when the weight is going through the knee joint. The actual deformity is shown. Sometimes you get an X-ray in sitting or a lying down position. The joint lines appears okay but once the patient is weight bearing, got an weight bearing X-ray done, so joint lines is reduced. So best is weight bearing X-ray and MRI only in the early stages, not in the later stages. So management is, it starts with the lifestyle modification, like you need to restrict some high impact exercises and start doing some low impact exercises like walking, swimming, cycling. Walking is the best exercise because walking increases the nutrition of cartilage through the joint fluid. As we walk, cartilage gets the nutrition from the joint fluid. So those person who walks a lot gets lesser osteoarthritis than those who don't walk much. So one of the factors in urban population is not walking much. That's the reason rural population is having lesser number of patients than the urban population. So walking is directly related. And initially you can start with paracetamol, SOS, then the drugs, NSAIDs, COX-2 inhibitor, even opioids can be given for the pain management. Injections can be given if the pain is not subsided with the your routine drugs. So hyaluron injection is there to increase the viscosity of the joint fluid, so the friction is less and patient gets benefit. But it helps only in the early stages of osteoarthritis, not on the later stages or a stage 4 arthritis when you need some surgical management. Steroid injections also given. It helps in patients those who have inflammatory symptoms like swelling, like inflammation all around the joint. Synovitis is there, so it's the best anti-inflammatory steroid. You can inject inside the joint and get a relief for few months to a year depending on the symptoms and the stage of the disease. And finally, the surgery. If the patient is not getting relief from any other treatment like lifestyle modification, medicines, injections, so patient is a candidate for surgery. In surgery, there are uh, so in drug management, there are some glucosamine supplements, chondroitin, collagen supplements are there. Some newer drugs are coming. They're Boswellia serrata, Loseb, Devil's Claw, Curcumin. They are anti-inflammatory supplements, can be taken. but they generally doesn't change the natural course of the patient's history. They might relieve, might not. So no proven medication is there for osteoarthritis. Painkillers are there. Diasterin is one disease modifying drug for osteoarthritis, but it has a limited role in only grade 2, grade 3 osteoarthritis. So surgical treatment is there, and the types of procedure we can offer to the patient is arthroscopic irrigation or debridement. Second is high tibial osteotomy. Third is partial knee joint replacement, and fourth is the total knee replacement. So in arthroscopy, it's not only just cleaning of the joint, it is generally fixed to the specific structural damage that is there. When we see in early osteoarthritis, generally done in early osteoarthritis, when we need to repair any meniscal tear is there, remove any torn meniscus fragment, or any loose body that is causing mechanical symptoms. So arthroscopy should be limited to these fixing these structures damage, not just the only cleaning of the joint, because it will not help the patient. Or synovectomy. If you had a synovitis, you can take the biopsy, you can reduce the burden of the disease by doing a partial synovectomy. Next is high tibial osteotomy. And indication of high tibial osteotomy is unicompartmental arthritis, only one side of the joint. Knee joint comprises of three compartments. One is medial compartment, one is lateral compartment, and the third one is patellofemoral compartment. If in these three compartments only one compartment is damaged and all other compartments are okay, then you can go for this correction of the alignment because of the varus or a valgus. So you realign the mechanical axis by doing a tibia osteotomy. High tibial osteotomy is the osteotomy at the proximal tibia and fixing it with a plate, like you can see in this X-ray. There is a only medial side of the joint is damaged, and it is being fixed with a high tibial osteotomy. So it generally gives a good mechanical access to the patient. The weight bearing axis is changed from middle compartment to the better lateral compartment, so patient gets a good relief for years down the line. Generally done in younger patients depending on the symptoms. Same way, partial knee arthroplasty or unicondylar knee replacement. The indications are same as high tibial osteotomy or HTO. The unicondylar knee replacement is done only in selective patients. The age should be less. Second is the only medial side of the joint, medial compartment of the joint is osteoarthritic. And the ligaments, ACL, PCL, MCL, lateral collateral, all the ligaments are spared. There is no diseased ligament or torn ligament. If any one of them is not there, you cannot perform partial knee joint replacement, right? So the benefits of partial knee joint replacement is the smaller scar, increased range of motion, faster recovery, but the prosthesis survival is 10 to 15 years. So it might need a second surgery for a revision to full complete total knee replacement. So this is some few x-rays how they look in x-ray. You can see this only middle side of the joint is replaced, same this side middle side of the joint is replaced. So it is known as unicompartmental knee replacement. So this is one of the things that we can offer to a younger patient. Only part of the knee or one compartment is damaged and other compartments are fairly good. The final solution, if everything is not getting in line, and is total knee replacement. This total knee replacement word is a misnomer. Like thing, because in patient's perspective, if we think total knee replacement, patient thinks the whole of the my femur bone and the tibia bone is removed, and some whole bone and plus something is whole of the joint is taken out, and some other artificial joint has been created. Rather than we say total knee replacement, it should be total knee arthroplasty. It's just a word game, but it is just the capping of both the side of the joint that is worn off. We are not replacing any bone, we are just replacing the bone of cartilage with the metal implants, with the spacer, plastic spacer, tibial component. You can see in the this view, plastic spacer in between, so that the now the friction is between the metal and the plastic. So benefit is better alignment, pain relief, increased mobility. You can climb stairs. These days, the implants that are available is you can squat, sit cross-legged, even offer namaz. Um some of my patients come from Uzbekistan and Afghanistan initially, not now. So they need to kneel down for namaz prayers and for daily rituals. So they are doing it after knee replacement because of the high flexion implants available these days. So what are the newer advancement in this total knee replacement? The foremost is robotic TKR. Now we are having robotic TKR with us. Second thing is painless TKR. Initial days, I started doing total knee replacement since last 14 years, 2009, I'm doing it. So initial days of my practice and whom I have seen in my learning days, the pain is dreaded pain. Post-op pain is dreaded pain. Patient सबसे ज्यादा पेशेंट एक लाइन से बहुत डर लगता है, दर्द बहुत होता है, तो दैट वी taken care of by doing some individual things, a cocktail of work that is being done for painless TKR. One of them is robotic TKR, another is some cocktail of medicines, intra, post-op, pre-op. The third new advancement is the joint survival, the implant survival. Initially, it was in thought that it will survive only for 10, 15 years, maybe 20 years. But now these days, 30 years joint survival implants are available in the market with zirconium oxide or titanium uh, alloy coating. So this titanium alloy coating or zirconium oxide coating causes one more betterment in the joint is no metal allergy. So some patients have a metal allergy with cobalt chrome material. Primarily, all the joints are made of cobalt chrome, the metal. So some patients are allergic to them. With the advancement like coating of these joints with titanium or zirconium, the metal allergies are very less. They are made more biocompatible because of that. And with newer high flexion design of the implant, you can sit squat, sit cross leg with that. So coming to robotic TKR, what is new in that and how it works? We get an precise bone cuts with near zero error because it has been taken care by the robot. And how it does its work, we get a CT scan of an patient, and once the CT has been done, we make a artificial limb alignment, hold the femur, tibia, knee joint. We take measure the mechanical axis. We measure the deformity of the patient, and with the deformity with the mechanical axis, we prepare a plan to how much bone is to be removed from where, minimum bone, so that we can put up implant with the better alignment, with the better less of the bone cuts and better uh, correction of the deformity. So in this, muscle cut is less, tissue handling is less, no repeated knee dislocation, so less pain, precise limb alignment, and early, because of these things the patient is discharged early, and there are many benefits because of the precise bone cutting. So better feeling of a natural knee joint, because it is more aligned with your mechanical axis, the natural mechanical axis that is there with the patient. So initially TKR has been done for the last 35-40 years all around the world, and 20 to 30% of the patients undergone knee replacement are not happy with their knee, and it is because you correct the deformity in the knee, but overall alignment from hip to ankle, sometimes it is not recreated. So patient feels something abnormal in the knee, not a natural feel. With the robotic TKR, you feel a natural knee feeling. You will not feel anything like artificial, because the natural alignment has been recreated. Second is painless TKR. As you can see in the photo, this lady is just third post-op day and third or fourth post-op day, sitting nicely with cross leg. So what I feel in painless TKR, what I say is pain is just like a fire. So if I know I am going to ignite a fire in the knee, so I need to put something prior to it so that fire doesn't start there. पानी डालते रहो थोड़ा 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 थोड़ा. पानी क्या है? The painkillers. So it is not given too much, but it is given in a rhythm, so that once one painkiller's efficacy reduces, then the other painkillers starts. So patient gets a 24/7 pain relief with a lesser drug with some time foundation. So we start pre-op paracetamol, etoric oxy, pregabalin, and counseling, good counseling of the patient. So patient is mentally and physically uh, able to handle the post-op issues. Intraoperatively, we generally get robotic surgery, so lesser pain because of the lesser bone cutting, lesser tissue handling. We use mid-vastus approach, no muscle cutting, so lesser pain. We don't use any tourniquet, so tourniquet pain is not there. So tourniquet is also causing ischemic damage to the muscle. So no tourniquet, no ischemic damage, no pain to the muscle. We use cocktail inside the knee joint. So the knee joint inflammation post surgery is limited, and in post-op we regularly use epidural or adductor canal blocks to reduce the pain of initial 2-3 days of the surgery, and paracetamol, diclofenac, tramadol at regular interval for initial 2 days only. Once patient passes that 48 hours of the surgery, the patient is practically pain free, and after that we can reduce the dosage. So now I'll just show you some of my videos.
Right, yes, we can see it now.
See, this patient is walking with such a gross deformity, with such a limp and a pain, and after surgery, see him walking, right?
Yes, we can see. Right, true. The deformity is gone.
Deformity is gone. See him walking after 2 months.
Awesome, very nice.
Now you can see.
Yes, wonderful.
So the same patient after 2 months of the surgery,
Smiling.
smiling. So no pain, no issues, all walking straight, right?
Yes.
I'll show you some pain-free patients, how they walk. You seeing this?
Yes, we can see this.
This is fourth day of the surgery. This is it. This is from Venkateshwar now.
हम्म। कितने दिन बाद एम्बुलेशन शुरू कर देते हैं?
Second day, 24 hours.
अच्छा, विद इन सेकेंड डे, बाय सेकेंड डे, ग्रेट। एंड लाइक ये वाले जो न्यूअर इम्प्लांट्स, दे यू से कि 30 इयर्स तक दे वुड
Yeah,
कीप द
30 years
पेशेंट?
तक they last.
राइट, राइट। So there are many, just like you said, there are many reservations of patients regarding the surgery. कि
Yep.
नहीं जाना है, वो पूरा और खराब होगा, पेन होगा, चल नहीं
Mm-hmm.
पाएंगे, because for few months they think they would not be able to walk.
Mm-hmm.
So those definitely are the reservations that you clarified today. और बेसिकली कई बार ये भी होता है कि एज रिलेटेड, व्हाट इज द ओल्डेस्ट पेशेंट दैट यू हैव ऑपरेटेड?
85. I'll just show you one. This is one of my patient. You can just see the age at the face of the patient, because I have not asked the patient to show the. Just see her walking. Both the knees are replaced, and she is 85 plus.
Right. So age
You
is not a
can.
bar.
Age is not a foundation, because if the patient's general condition is okay, if his or her heart, kidney, liver, lungs, four organs working optimum for her age, then patient is fit for surgery.
Right.
So it's not about age, it's not about weight also. I can just show you weight, heavyweight patient. Just I'll just show you this video. She is around 80 kgs and 5 feet height.
Must be around 38-40 BMI.
Uh,
She appears young.
yeah, she is 50 only. 55, 50. I think.
So age, weight, genetics. Do you think genetics play a role?
Yeah, definitely genetics play a role, ma'am, because our genes, definitely it plays a role in obesity, it plays a role in cartilage, it plays a role in bone density, and genetics plus epigenetics, like what we eat, how we walk, what we do with us, also plays a role. You can see कि दादी अभी ठीक है, but माँ का घुटना बदला जा रहा है. ठीक है, बच्चे आगे बात करें, दादी अभी ठीक है, बट क्योंकि दादी यूज्ड टू लिव इन रूरल कंडीशंस, शी यूज्ड टू वॉक मच, do much of physical activities, but because mother started living in Delhi, not much of walking, homebound practically, थोड़ा बहुत चलते हैं, going down, that's it, and they are all living in floors, no lift, so practically they are homebound, so they are not walking much, so they had a more of arthritis because of that.
Hmm. अच्छा, मुझे बताइए कि we always talk about osteoarthritis of the knee, but osteoarthritis can affect other joints also, like
Yep. Yeah,
so
it's
they have.
commonest in the knee joint, and the second most commonest is carpometacarpal joint.
जी,
The thumb joints. The thumb
जी,
joints is the second most common joints. Spine. What we say is spondylosis is the osteoarthritis of the spine, right? It's like cervical spondylosis or a lumbar spondylosis. There's an osteoarthritis. The disc is degenerated, the facetal joints are getting osteoarthritis, and the patient is commonly having only back pain, severe back pains, not relenting to anything. So they are osteoarthritis of the joints, spine. And second is post traumatic. You can get any joint post traumatic. Shoulder generally gets an arthritis because of the rotator cuff tear. Chronic rotator cuff tears causes complete massive tears, causes rotator cuff arthropathy or osteoarthritis. But they are not weight bearing joints. The patient generally tends to ignore them, like thumb, like wrist, like elbow. Elbow is commonly post operative, post arthritis only. post-traumatic, commonly post-traumatic or post-rheumatoid arthritis.
Right.
And any joints can be osteoarthritic.
Hmm. And I think TM joint, I am
Yeah, definitely, ma'am.
TM
Temporomandibular joint, but we don't. I don't see temporomandibular joint patients. So temporomandibular joint is also any synovial joint, any, and not only synovial joints, any joint in the body, like acromioclavicular joint. It's not a synovial joint, but it's also gets osteoarthritis. Sacroiliac joints, they also get osteoarthritis. So any two surfaces that had some movements or minimal movements can get an osteoarthritis.
There was a question from the audience, actually at the beginning of the talk only, that Dr. Vivek Bajaj, he asked that if there is a degenerative disc disorder of L4, L5 and right side sacroiliac spondylolisthesis, is it going to last for a long time, or is there a long-term management strategy that we can?
Long-term management is your activity lifestyle modification. Activity, some activities are restricted and some activities are promoted, like walking is being promoted. You can do cycling, but weight training restricted. My lightweight training you can do, and regular back exercises. So you need to strengthen the muscles so that the muscles will take the weight rather than the degenerative disc. So if you do good exercise, good walking, good physical activity, keep the weight low, reduce your sitting. Sitting causes back pain. The most commonest cause of back pain is these days is sitting, prolonged sitting. So sitting in a proper posture, sitting with back support, sitting not for a long time, try to walk in between. So these things helps a lot, and in between whenever there is a pain you can give pain physio for that particular time.
Right. And I think also the watching mobiles and screens and televisions in lying down position. So that
Yeah, mobile is the culprit for most of the neck pains. Now these days only you can get a neck pain, proper neck pain like an adult in 12-wear kit.
yes, same.
Post COVID, I have seen small kids coming with the back pain, neck pain of a like an adult one, because they used to with the mobile tabs, laptop, and they are lying on bed and doing all the stuff like maybe padhai bhi chal rahi hai, but all the stuffs on, they are hooked to the mobile. Their screen time is now 10 to 12 hours per day.
Hmm.
So they'll have the same pain as the adults.
Right, because a lot of children are coming with cervicogenic headaches also, and
Yep.
when their posture is very poor, their
Yeah,
physical activity.
definitely, ma'am. As much as the screen time is increasing, you'll get all the pain like an adults. Prior to, I have started my post graduation from Safdarjung Hospital in 2002. At that time, back pain, neck pain are mostly limited to tailor driver, and within few years, all the IT professionals have taken that seat. So now I'm seeing 23, 22 because they get an early job. Even prior to that, they are almost working half of their day on laptops or mobile. So with the wrong posture, they'll get a pain.
Hmm. Right. Is there any role of nutrition in osteoarthritis?
Yeah, definitely, ma'am. Initial days in our Indian population is generally vegetarian, but they used to take a lot of milk and milk products. घी,
Hmm.
देसी घी, दही, घर के अंदर दूध, they take lot of milk products, and milk products is almost an animal product. You get good protein from that, you get good fat from that, and you get good calcium from that. So they used to take lot of milk and milk products, but these days milk products are less, and the protein diet is limited, calcium diet is limited, and those who are in living in urban population, so they are mostly confined to offices, not exposed to the sun. So vitamin D deficiencies are there from that side, and they don't had an habit of walking for smaller distances. They take all the vehicles for small distances also. So they get osteoarthritis, back pain, neck pain, all the joint pains, because muscles are not conditioned, nutrition is already lacking.
Hmm.
So they generally develop these things.
And generally, I mean, you have for females, I think they have to make sure that their bone density is good before menopause,
Yeah.
because that
Uh-huh. It's
after that.
your the bone density is just like your fixed deposit, right? You need to maintain that bank balance, and with the depreciating bank balance. In fixed deposit, you get interest, but in bone density, your bone density decreases 3% per year after menopause. So you need to build up that prior to that.
Hmm.
Prior to achieving menopause, you need to build up your bone density and a muscle mass also. Both
Hmm.
things are equal, not only calcium, with a protein also.
Right. I think डॉक्टर साहब आपने सारे सिम्टम्स मैनेजमेंट न्यूट्रिशन एंड पोस्ट ऑप केयर कितना रहेगा, सर्जिकल ऑप्शंस कौन सी है, रोबोटिक क्या चीज़ होती है, ये सारी चीज़ें आपने बहुत अच्छे से आज समझाई हैं. इंफॉर्मेटिव टॉक दैट वी हैव हैड टुडे. आई थिंक ऑडियंस का भी और कोई क्वेश्चन नहीं है. यू हैव ऑलरेडी आंसर्ड ऑल द क्वेश्चन. लॉन्ग टर्म में क्वालिटी ऑफ लाइफ, दिस इज ऑल अबाउट मेंटेनिंग द
हाँ,
क्वालिटी.
डेफिनेटली क्वालिटी ऑफ लाइफ. एंड एक लाइन और मैं बोलना चाहता हूँ इस पॉइंट पे कि लोग बहुत सारा ऐसा सोचते हैं कि नी जॉइंट ही खराब है, अब तो खराब तो हो ही चुके हैं, अब खराब से और खराब क्या हो जाएंगे. बट दे डोंट थिंक कि बाय नॉट वॉकिंग and by walking in a waddling gait this like this, they are damaging their spine, they are damaging whole of the body. बिकॉज लाइक जैसे मैकेनिकल अलाइनमेंट हम अपने गाड़ी के टायर का कराते हैं, वैसे ही हमें बॉडी का भी मैकेनिकल अलाइनमेंट स्ट्रेट होना चाहिए. अगर हम उसी पे चलेंगे तो हमारे एंकल जॉइंट्स, हमारे फुट, हमारे हिप जॉइंट्स, हमारा स्पाइन, दे ऑल टेंड्स टू गेट पेन. ठीक है. तो एक प्रॉब्लम थी नी जॉइंट में, हमने और बढ़ा ली, तो वो
राइट.
नहीं करना है. वी डोंट नीड टू स्ट्रेच टू मच. Many newer things are available. It's a wonderful surgery with very good results. With the newer advancement, things are getting better each day.
Right. A stitch in time saves nine. And I think stay in touch with all of us with the knowledge. And we always believe it is the knowledge or good knowledge that leads a professional to the top of his profession. And thank you, Doctor. Thank you, Dr. Ashu.
Thank
And
you. Thank you, good evening. Good day to all. Thanks a lot.
good day. Good day.